Great.
Okay. Hi, everyone. Welcome to Analysing Events and Timelines in Public Health Emergencies, Part 2. Apologies for the slightly late start. We're going to kick off straight away with Mark, who's first on the agenda because originally he was only going to be able to present and then leave us. But I think, Mark, you're going to be able to stay for the whole session. Fantastic. Yep. Thank you. So Mark Dipp from the London School of Hygiene and Tropical Medicine will be presenting on using panel regression models to estimate the impact of public health and social measures on SARS-CoV-2 transmission in different countries.
Great, thanks. Thank you for the introduction and thanks for the invitation to speak. So here are my slides. Well, I'm going to speak mainly about something we did quite early on in the pandemic, but we've been actually doing some extra work to take it forward with another year's worth of data, although that's still in sort of a preliminary stage. And it's not actually about interrupted time series, although it's also about looking at the same issue, which is when you have basically in this case, ecological data about an outcome and interventions. How can you use that then to look at what the impact of the interventions would be? So in this case, the interventions are all the different public health measures we had for COVID. And the outcome is that, the transmission of COVID. And fortunately, we had two really nice, two very convenient data sets that we could use for this. On the public health and social measures side, we had the Oxford Coronavirus Government Response Tracker, which really looked in a number of categories at the intensity and of different interventions, categorized into different categories from sort of really no intervention to the highest intensity of interventions, and split across different categories like maybe schools, workplaces, travel restrictions, and so forth. Most people know about the actual index, which is a number between 0 and 100, which is a bit of a blunt instrument, to be honest. But behind the index, there are lots of different categories of interventions. And then the second is, daily estimates of the reproduction number that was basically estimated from the number of cases reported in these countries from Epi Forecast, which I see Sebastian Funk is here. He's the person who actually led this initiative. So all questions on that could even be directed to him, but I think it was a really nice source of estimates for RT over the same time period. And because of that, we could then link the two using a fixed effects panel regression with a large number of time points. So we looked over the first phase of the pandemic when countries were imposing their various public health and social measures for COVID. And then afterwards, when sort of like summer started, summer in the Northern Hemisphere started, a lot of countries started to turn off these interventions. And so we had an interesting effect of being able to look to see whether there was a different effect in turning on and turning off. And so it's a sort of fixed effects panel regression with each of the policy interventions as time-varying covariates, so that we could look at the strength of relationship between them, the coefficients, and then an error term which represented country-level variation. So there are a number of issues we had to deal with when we looked at these data sets, and this is probably the most relevant, I think, to this meeting around interrupted time series. And I think these were the different issues, interpretation issues we had when we were looking at the data and the results of the regression. First one was what I said, symmetry. So we managed to get enough of a time series to look at what happens when interventions are turned off and then turned on. And one question was, actually, do they have the same effect? Did turning them off have a different effect from turning them on? I mean, not just the opposite, but actually does it bring RT, the change in RT to a different place when you turn them off? So we ran the model on a truncated time series, looking for the peak time of public health and social measures, working that out and seeing whether running it with the truncated time series gave a different result. Second is, are there temporal lags? Because you put in a policy intervention and then it might take time to actually change the reproduction number, especially with some of these interventions, like for instance, financial support for people who have to stay at home, for instance, might take a bit of time before it actually feeds into behavior change. Third of all, and this was the most challenging issue that we faced, was clustering. And it's the fact that the policy interventions were highly temporally clustered. For instance, around March, all countries were imposing many different interventions, within a short within a short time space of each other. And as a result, it's very difficult to independently identify the effect of individual interventions when actually most countries close schools and close workplaces at around the same time. And so what we did was to try to cluster the public health and social measures, and then try to interpret the results based on what we could see in each of the clusters. And I'll talk a bit about how we did that in a moment. Next, we looked at sequencing, whether, for instance, closing workplaces and then closing schools would be different from closing schools and closing workplaces. And then lastly, model specification. How do we actually decide what to specify our model with? And do we need to do some kind of variable selection? And so we tried to do that as well. I'll very briefly go over how we did everything. I'm guessing people are less interested in the results because this isn't a COVID seminar. This is quite old data in any way, but I'll talk about some of the implications in my last slide. So first of all, looking at the temporal trend, you see this effect where lots of countries started imposing public health and social measures to a very high level, probably the highest level ever, really, across the whole pandemic by sort of March, April of 2020. And then by late April, there was a turning point when countries gradually began to relax these interventions. And so we could look at a truncated time series to that peak in 13th April and then the full time series. And you can see the same in individual interventions, the same sort of temporal trends to a peak and then actually plateauing or gradually decreasing the interventions after that and across the different regions. We also looked at different temporal lags. So we had different scenarios looking at, maximum effort is to say we only considered the intervention to be on when countries reached the maximum level of effort. For instance, like for school closure, maximum effort would be schools closed for the vast majority of the population, whereas the intermediate levels will be only certain types of schools or certain ages of school children are not going to school, and minimum and then any effort would be any kind of intervention, no matter how mild, and multi-level would be using an ordinal variable rather than a binary variable to represent the intervention. And across all three, we did see actually there was across different regions, maybe interestingly, different levels of temporal lags, which looked like optima when we considered the goodness of fit of the model, but generally they're around the sort of like between 5 to 10 days sort of region, although the slope of this wasn't very distinct in most regions. In sequencing also, we found that there was sort of like a sort of pretty skewed distribution overall when we looked at the number of interventions, but actually there was sort of like some symmetry in the sequential order of interventions, which suggested that maybe there was sequencing, there was some kind of actually sequencing to the order in which these interventions were imposed. And then the clustering, which I think was the most important and most challenging issue. What we did was we did some cluster analysis using Ward's method on the different interventions. And whether we looked at maximum efforts or any efforts, we got a different kind of clustering. But basically, all the interventions fell into either 2 or 3 categories of interventions that were very strongly temporally clustered. And so when interpreting, we took into account this clustering, which I'll talk about in a moment, but take into account that within a single cluster, it is actually not really possible to independently identify the effect of individual interventions, even though, if you run the statistical model, you will get a result. And then for variable selection, what we did was we ran this on the full time series and the truncated time series, both looking at any effort and maximum effort and using both AIC and BIC as our variable selection method. And so what we did in the end is to ask ourselves, well, is the policy intervention actually clustered with other interventions? If all the interventions within a cluster all had significant positive effects, we took that as actually good evidence, strong evidence that actually all the policies in that category might actually be having an effect. But if the policy intervention was clustered with other interventions which were not significant or had an opposite effect, then we can't say for sure that actually that policy intervention has the effect that's indicated. It might simply be sucking up some of the effect from the other interventions in the same cluster. We also wanted to make sure that, well, the effect sizes were significant, that whether they were positive or negative, and also ideally we wanted to make sure the policy intervention was selected across the different scenarios, the full time series and the truncated time series, both AIC and BIC, and with different lags from 1, 5, or 10 days. So we were being exceptionally conservative because this was ecological data, because there were these issues involved with interpreting the data to see where we would get. And so if we restricted only to those variables selected with a significant negative sign, and which, let me say, decreased RT, which is the intended effect of the interventions after all, and we're in a cluster with a variable, not in a cluster with a variable with a significant positive sign, so that less of a possibility that they were simply sucking up the effect from another variable, then we said there was strong evidence that there were two policy interventions falling in that category only: school closure and internal movement restrictions. So restricting people from moving within a certain country or smaller region, like not letting them move within a certain radius of home or things like that. Moderate level of evidence was when the variable was selected with a significant negative sign for at least 2 of the 3 dimensions. So across these AIC, BIC, across all full effects or any effects, and across truncated and full time series, we let one of them lose significance, but not more than one, but still kept the sort of like requirement that it was in a cluster with a variable with a significant, not in a cluster with another variable with a significant positive sign. And there we had a number of other policy interventions. Most of them fell in that category. Whereas there was a third where even that level of evidence, we could not really find evidence that this was having an effect. And I mean, testing and contact tracing was the interesting one because I mean, some countries have used testing and contact tracing very successfully, you might argue. I think the challenge is that this is really a sort of small minority of countries which had a really very, very high level of capacity for testing and contact tracing, almost being able to contract every single sort of case, or close to every single case, using both forward and backward contact tracing and so forth. And there's a very small minority of countries in the world which used it successfully, whereas the vast majority of countries in the world did some level of contact tracing, but to not to a very useful extent, especially when the epidemic started to take off. And because of that, the Oxford tracker wasn't really able to distinguish between sort of like these levels of intensity of contact tracing. But anyway, some conclusions and recommendations from this, which might be useful to other kinds of ecological analysis. First of all, because it's ecological, it's observational, all we can show is temporal association, not causality. So even though we have this list, all we can say is there's evidence that, you know, that interventions in the strong category have had an effect on RT, but this is just one piece of evidence that we can never prove causality using these kinds of methods. Second of all, there are all these issues I've talked about already, and all these features really need to be taken into account. And so in the end, what we really had to do is look at all the look at the results of all the different models we ran, and then start categorizing them into different categories, and coming out with a method of categorizing them in the end. But this isn't something that we sort of like were able to do right at the start, you know, set up a protocol, put an algorithm, run the computer, and get the results. We really had to check on every level what's really going on. There's these temporal effects going on. There's this asymmetry of effects going on, and then add extra dimensions to analysis. So I think a purely sort of a priori algorithm is never going to be able to analyze complex ecological data. You always need like really careful human interpretation of the data at every step. And we made sure that we did that interpretation level with 2 independent researchers who did it separately and then came together and discussed to make, well, not impossible to eliminate, but to try to minimize human bias, so that, you know, the independent researchers looked at the data, said actually to interpret this data we need to have these criteria, came together, each of them said what they were doing, and then they discussed it and came up with a consensus way forward. And then, well, despite the limitations, some signals were clear. I mean, there's still signals, but there was strong effect for some interventions, and the interventions for which there were the strongest effects are not so surprising, given that especially this was the sort of beginning of the pandemic, when it was pretty clear that some of these interventions were having big effects. So that's all from me. Happy to take any questions.
Wonderful, thank you, Mark. That was an excellent presentation. I unfortunately lost connection at the very beginning, so I missed your first couple of slides, but hopefully I can catch up. Please do raise your hands if you have any questions for Mark. Oh, Esther, great.
Hey, Mark, great presentation. And I haven't read your publication, despite the fact it's already out there for some time. Apologies for that. I was just curious, they're just technical questions. And I was just kind of curious, because for the 2 questions I have, for the school closure and mobility restrictions, you found quite strong evidence. But I'm not quite sure, because you fitted the model to 130 countries, right? To what extent were these measures also more or less implemented at the same time and both affect mobility of the population? So to what extent are they actually not collinear, these 2 types of measures? And another question I was wondering, so if I understood correctly, you fitted a fixed effects model, but with a random intercept, it sounded like. But I can imagine that, especially because you fitted it to so many different countries, that these type of intervention can have different kinds of effects in different countries. So for example, travel, working from home might work in some countries, but in others very differently. What was the reason for not fitting random effects for all these interventions? Because of the complexity that it will bring to the model and the interpretation? Over.
Yeah, thanks, Esther. Those are great questions. So we did look at a random effects model as well, and then Christian, the sort of second first start author, is the sort of statistician in the group, and he ran a number of tests whose names I can't remember to show that actually the fixed effects and the random effects model were really giving roughly the same interpretation. And so for parsimony, we decided to stick with the fixed effects model. Apologies, I can't give you the actual technical detail, but I definitely can pull it out of the appendix and let you know. In terms of the sort of like the school closure and the restrictions on internal movements. Well, okay, these I'm trying to see which. So with the any effort scenario, these were in the same in the same cluster, and so in order for those to both have been get into the strong category, there mustn't have been anything else in the cluster that was significantly in the opposite direction. So we must have been able to find that's for instance, in this big cluster where we have lots of things, all of these would have had to be either all negative or non-significant in order for school closure and restrictions on internal movements to come out. Whereas in this cluster, I think we sort of ended up eliminating all of them simply because there was a mixture of signs in this group. And then we had to look at the other categories where they had to be consistently negative across all the different models as well, if that makes sense.
Yeah, if I may just follow. Yeah, I understand that basically what you just explained. I was just mainly wondering because both of them had all positive effects, right? Both your school closure and mobility restrictions. But I kind of was wondering to what extent, because I think school closure was implemented in many countries quite quickly after restricting mobility of the population, and I think school closure also affects mobility of the population. So to what extent actually school closure is independent from mobility of the population? So are they not very collinear That was my main question.
Yeah, I mean, in terms of temporally, they were collinear, which is why they're clustered together. So in terms of the interventions, then definitely this suggests that when countries impose school closure, they also impose internal movement restrictions, and when they turn them off at the same time. Whether there's a knock-on effect, like when you impose school closures, you also decrease internal movement. That's quite possible, but we weren't actually using the changes in behavior as the indicator variables. We are looking at actual policy interventions. So all this is saying is when there's a policy restricting internal movements, this is the effect. We're not saying anything about to what extent it affects behavior, which is the sort of like there's an intermediate part in the causality chain, right? You have the intervention, you have behavior, and then you have the change in transmission.
Yeah.
But, yeah.
Okay. In the interest of time, oh, Sebastian, would you like to ask a quick question before we move on?
Just really quick about communication, and because you could talk about these as effects, but then you say they're not causal. Don't you fear this could be misinterpreted as people thinking there's an effect of the policy on the reproduction number rather than an association, which might be mediated by behavioral change, which could have other causes?
Yeah, I think that is important, and I think we were exceptionally careful in our caveating things in our paper, but there's always that danger. I think it is evidence for causality, but it's sort of just one piece of evidence. It's not. It needs to be combined with lots of other evidence, and in order to, I mean, there's also a sort of biological plausibility or sociological plausibility that if you stop people from doing things where they have to go out, they are going to transmit less. But I don't think that, well, yeah, I agree. Countries shouldn't make policy on these kinds of analyses alone. They should also do sort of more careful analysis of more individual level data, in order to work out whether these interventions have been successful. I totally agree with that.
Thank you, Mark. In the interest of time, I'll save questions for discussion at the end, and we'll move on to Samir Bhatt, who's happy to touch on some of the points on fixed and random effects points in his presentation, how to estimate the effect of non-pharmaceutical interventions on COVID transmission, a brief tour of solutions and challenges. Samir, are you? Great.
Yeah, I can just try to share my screen and see if full screen works. Otherwise, I'll ask you to do it.
No, we can see it.
How about now?
Yeah, looking good.
Okay, great. So all looking fine, right? Yeah.
Yeah.
Yeah, I forgot the Imperial logo, but I'm Samir Bhatt at University of Copenhagen and Imperial College London. So don't rat me out to people at Imperial. Yeah, we're going to talk about estimate effect of non-pharmaceutical intervention. So touching on a lot of the points that Mark made, the excellent points Mark made. It's a brief tour of solutions and challenges. Now, there are a lot of papers on non-pharmaceutical intervention. So I've just focused on the ones I've done because we only have 10 minutes. And I'm going to go through the 5, solutions and the issues, many of which will echo what Mark says. So the first point to make is, what we're trying to do when estimating non-pharmaceutical interventions is creating a mechanism for reality, right? The reason we want a mechanism for reality is to constrain the space of plausible scenarios to those to be epidemiologically relevant. So that's why, essentially, I think that the first thing that someone needs to do when actually estimating the effect of non-pharmaceutical interventions is putting in a mechanistic model that accounts for the lags between interventions, infections, deaths, hospitalizations, accounts for a plausible mechanism for how individuals infect others, has a multiplicative or additive assumption for how transmission occurs as a function of these interventions. And so the first thing to do is a mechanism for reality. Now, before we look at any of this, a really important part of all of this, which I call epidemiological constants, but maybe there are better terms for it somewhere. A really, really important part of all of this is to have these so-called constants that give us fundamental parameters to parameterize within the mechanistic models. So I'm talking about things like the generation interval, the serial interval, the onset to death distribution, and other factors like this. Now, there's a huge amount of work that gets into this, and these need to be updated throughout. And it's something that I think London School has been particularly good at doing, and informing the rest of the community. But this is, this is the first starting point. Before we even start talking about NPIs, you first need to get this right. And this is the first thing that people tackle when some new infection comes about and we need to do things in real time. So the first attempt, which was, to my knowledge, the first paper on this on March 30th, was a paper submitted by my group. Sorry, I'm just getting messages here. I hope it's not interrupting anyone else's feed, but.
No, you're fine. It's not affecting us.
Oh, that's good. Yes, so the first thing that we wanted to do was to put this together in one big framework. And I know there's some equations. We don't have a lot of time, so let's just go through the core details, and then you can sort of read the paper, or for those more technically minded, you can sort of understand what I've written there. We use something called the renewal equation. The renewal equation has epidemiological motivations, both from the excellent work of Christoph Fraser and the work of Lochter back in the 20s. And it is rooted in a stochastic process, which is some work that we have done recently. So this is our model for reality. Then from this model of reality, we connect it to data on infections or data on deaths. At the time, March years, all we had was data on deaths, which wasn't great. And account for the lags in the process between a person getting infected, person showing symptoms, progressing over to hospitalization and going over to deaths. And interventions, of course, stopping the first stage, transmission, which means there's a lag until you observe the effect of this further down. And then put in a bunch of fixed effects, which I'm glad that Mark has introduces the terms, I don't have to introduce it, a bunch of fixed effects in there. So the first iteration of this, we put entirely fixed effects with perhaps not the most uninformative prior. We then did some iterations of this as time has gone by, and we've had to sort of do lots of discussions about this. But in summary, this plot is very coarse, but these summarize our first results, which is we looked at 5 interventions: lockdown, public events, school closure, self-isolation, social distancing. We tried many different models. The partial pooling model is exactly what has been discussed, which is this model where you have random effects and fixed effects, and the full pool model is a model just with fixed effects. And then you've got a model, which is the one we published, which is a bit of the mix between the both. Broadly consistent results between the two of them. But this paper did have a lot of problems, right? I mean, first of all, you can see from this little meta-analysis that justifies our results, as the first paper of all of these things, there were lots of issues, right? So number one, the issue of collinearity, which has already been raised, right? Now, collinearity is an insurmountable statistical issue, right? If you looked at just the UK, for example, lockdown and banning of public events happen on exactly the same date. So the statistical solution for this, there are two. You either pick a minimum norm solution or you pick a sparse solution. So you give all the weight to one or the other.
Can I quickly step in? Is your screen supposed to be advancing? Because we're not seeing it advance.
Right. Yes, it should be advancing. So can I just go like this? Is this okay?
Yeah. Can you zoom in a little bit? Yeah, that's better.
Yep.
Yeah.
So this is where I was saying the different models with fixed effects. This is where I was saying the model for reality with the equations. So I hope you've seen that, but if not, we'll just move on because the pictures are just there. It's mainly me talking. So there are lots of issues. For example, in the UK, complete lockdown banning of public events has exactly the same day. The collinearity problem like this requires you to do some form of regularization. We do the minimum norm solution. We split the difference, or you can do sparse solutions. There are many ways to solve this issue. The best way we think to solve it is from the social sciences, which is to look at many different countries at once. But of course, the big problem we had in this was the intervention definitions were really coarse, particularly lockdown. And this is where a lot of the toxicity around lockdown comes in, is that it is a catch-all term in our model here, right? Lockdown has so many more interventions than social distancing encouraged. And so it makes sense that it's the largest intervention because it's scooping up everything. So it was very, very coarse. It was national only as well. And as the pandemic progressed, lots of policies were made subnationally. As I said, there are unobserved effects in there. And we accounted for this, using fixed effects and random effects, but you can use a whole array of statistical tools to actually get random effects as best as you can. So we will use random walks as we move on. Then modeling deaths only was a problem. So we then integrated case data, and using other forms of data like mobility were important. So after we looked at NPIs and the effect on deaths, our second attempt was to integrate mobility. And here what we did was we took mobility data from Emodo, so a mobile phone company, and integrated this together with contact patterns to see, how many individuals were contacting with each other, and use that to help predict trends. Now, we were really happy about this, but as the pandemic progressed, we found this, as researchers have used this word decoupling, but really it's a non-stationary effect of mobility. The effect of mobility on transmission mitigated through contact matrix patterns was continuously changing. And so it wasn't this panacea that we hoped it could be to replace the intervention definitions as these binary interventions like stringency or that. So the second attempt on mobility we thought was very good, but it didn't really solve the problem. So in the third attempt, we just left it all and embraced randomness. And we said, well, let's forget about defining interventions and let's just use random effects. So get rid of the fixed effects, use random effects. Using random walks, which are a type of Gaussian process. In continuous time, it is a Gaussian process. In discrete time, it's just a random walk. And we use this in Manaus to understand epidemiological properties of whether the new variant P1 was more infectious and evading previously acquired immunity. And Manaus was a very interesting case because Manaus had this epic wave, and then largely individuals thought there was herd immunity at that point. That's what the blood banks were saying. And then we see another wave come about. There has to be an epidemiological discussion for this. Either we got the number infected completely wrong, there was large amounts of immune escape, higher amounts of transmissibility, changes in behavioral patterns that are reflected in the reproduction number. And we had to test which of these hypotheses are most plausible, and that's what we did in this attempt. But still, we weren't that happy at answering the original question of how does one estimate the effect of non-pharmaceutical interventions. So then on the fourth attempt, we teamed with another group that had used our results to do some other work on non-pharmaceutical interventions and did a really huge project where we tried to solve all the problems I highlighted. We did it subnationally, we used a random study design, we tried to get the best definitions of interventions, we used a multi-country analysis, we used both case data and death data, we used both fixed effects and random effects, and most importantly, we did a lot of sensitivity analysis, although, we could have done more sensitivity, made this multivariate, but univariate sensitivity analysis, and really to get an idea of, what were the levels, if a government is asking what you need to do, if you could provide this graphic every week and see the changing of it, I think that would be useful. But as Mark said, not all of it, but that would be a useful component to then calibrate your choice on decisions for policymakers. But there were still problems in this, and this is where things get really complicated. These interventions are occurring on a landscape of behavioral changes. They're continuously evolving, which means you need to run these models like you do all other mechanistic models every week and get updated estimates. You need to update the interventions, and it really is a large endeavor. And ultimately, these non-pharmaceutical interventions are simply just a proxy for behavioral changes. So really, we should be looking at behavior, not just these. We also find that these results don't tend to generalize outside of your study set. So we do this for, I think it was 14 countries. Now you're asking, well, can I just apply this in South Korea? Absolutely not. That doesn't work at all. It doesn't even mean that you could apply the same results in your own country's third wave, because it's highly non-stationary and highly non-generalizable. It sort of has large ties to economic, cultural, and behavioral impacts within a country rather than being some sort of absolute fixed coefficient. And I think this is something that hasn't been communicated well enough, and we are guilty of this as well, because it is a hard thing to communicate, especially when you're trying to get your papers published, how useful these results are. Then finally, we moved to the fifth approach, which was, let's just forget about doing all of this in a two-stage approach and try to do something fast and quick. And we did this for the tier where in the UK, and what we did was we used an estimate of R, of which there are amazing bits, modeling groups coming in, and lots of theory being placed now on how to estimate this using ensembles. And then did a standard statistical analysis using latent factor models on top of this to estimate an effect size of what we're interested in. So we're saying, let's first estimate the rate of transmission, accounting for all the lags and all of that. And then let's see what can best explain this trend. using random effects and fixed effects. And so the sort of random effects here we call secular effect sizes, and this is just a SPI-M legacy for using that word, but just call it a random effect because that's actually what it is. I don't know why it was a weird time. Let's just put it that way. So I want to quickly move on so we can stay on track and not go in. So, what have I learned from this? And I say I, not because I'm trying to be egotistical, but because there's so many things that could be learned from all of us on this. And this is just a personal take on it. This is not a one-off exercise, right? If you have to put this into your pantheon of established methods, right? It's a difficult challenge estimating R non-parametrically. Now you need to add a parametric estimation of R in multiple different ways, two-stage, random effects, non-random effects, and do an ensemble on it, and then get a consensus of interventions. But obviously you need to sanity test all of these. Joint model is obviously better for a range of questions, like I said in the Brazil context, but the two-stage model is faster. So if you have to do things really fast and you have, for example, a group of researchers producing estimates of RT daily, well, you might as well piggyback off that to get an estimate really, really fast. NPI definitions will always be far less useful than actual metrics on behavior. Behavioral studies, like comics, but beyond that, need to be sort of invested in primarily, right? There has to be investments in here to do this. We can't sort of we've squeezed out as much as we can from it. I think that is clear. We don't know enough about contact patterns, I feel, right? We have the polymod and comics again, but this is, we really need the data, and I don't know where to get this from. I've been trying for mobile phone companies for the better part of 5 years. I thought the pandemic would allow it to happen, but still it is challenging to get really good information about contact patterns. And as a personal thing, I think the maths behind the mechanisms needs to be expanded. They're all essentially the same thing, these models. We need a unified stochastic theory for all of them. So that's my talk. Thanks for listening, and have any questions or
Thank you, Sam. That was great. Thank you. Please, everyone, do raise your hands if you have any questions for Sam. I think it was really interesting that you actually raised the quite important point that people's behaviors will change over time to the same MPIs, so the same policy changes or whatever, and it's not static.
Yeah, what we found was the effect of the combined interventions of lockdown or banning gatherings greater than 2, which is what it is. Between the first paper and the second paper, we saw quite a large change. This was also seen in the work of John Edmonds at London School initially, that there was a change in how important it was. And then we tried to generalize our estimates to the third wave, and we found that the second wave generalized much better to the third wave. And the obvious explanation is that sort of some people's behaviors on certain dimensions became very stable. And you see this in both YouGov and comics data, where you see a very flat line of behavior for a large part of the pandemic. So it isn't just behavior, I should add as well. It's also what we call in the paper background interventions, right? So now when you go into a shop, there are screen masks there, right? People are sanitizing a lot more. So it's not just the behavior, but also we got a lot better at the second wave at preventing transmission from a host of these background facilitating interventions. And so the effect of NPIs was less, but the reproduction number was also less. So the absolute number isn't, say, as critical to look at. It's what combination gets your R below 1. That's the objective from policy.
Yeah. No, interesting. And Esther.
Do we have time, or because it's more kind of a personal interest question?
Yeah,
no, go for it.
I think, well, I think it's also relevant, but I remember giving a talk at Epidemic using kind of a spin-off of the comics approach or polymorph approach, basically. And then being asked in the panel the question, okay, you've all now presented different ways of measuring mobility and measuring, in that sense, human contact. You already mentioned over the pandemic, the impact of an encounter also might have been decoupled a little bit. And I think there have been some publications on that as well, right? That showed that, for example, Google mobility data has kind of starting to measure something different over time. But I'm just kind of wondering, is anyone investing now in efforts to compare these different methods like comics, Google mobility, contact tracing data, mobile phone data, to kind of evaluate, okay, do they measure the same thing? Do we see any kind of superior performance of either of those in particular times of the pandemic? Like any kind of effort around this to see for future pandemics? Yeah.
I mean, it's a fantastic question, and the answer is yes. You know, at a meeting with this HPRU that Seb and Mark and I are part of, we discussed exactly, you know, this movement from not just using NPIs, but using the behavior and trying to do a big statistical exploration on the balance between them, right? But it is so challenging to do, right? Because I talk about a mechanism for infection, but then now we also talk about the mechanism for how these interventions, you know, feed into the mechanistic model, right? And we're all just using linear terms or something like that, or some sort of function. We're not actually using, you know, like what we did with my colleague Ollie Ratman in this paper here, you know, via contact matrices. But this had a lot of constraints in it, which meant it wasn't as statistically free. So, I mean, to answer your question, this needs to be done, and it needs to be a concerted research agenda. I just don't know. It's huge. It's a huge project. I just don't know, you know, sort of how exactly we would do it. But it is something I do want to do in the future, which is to get the balance of all of these together, understand how behavior links in with the NPI definitions. And I think it'll have to be multifaceted, right? Looking at how behavior links with things like comics and behavior and NPIs, how transmission links with that, how that affects with GDP is something we're looking at in my group right now, and look at it from a whole multifaceted view on how transmission gets affected in all the different ways. But, you know, in an ideal world, what I would be given was contact matrix patterns and behavioral surveys, or, you know, in the same way as, what's it called, like the ONS survey or the REACT, and then use that for statistical estimation. That would be the better solution. But, you know, historically, I do think a very open and important question that needs to be done is exactly what you articulated, exactly as you articulated it, I think.
Okay, thank you, Sam. I think in the interest of time, we'll have to move on, but really interesting discussion, and hopefully we'll have a couple of minutes at the end to touch on some of these points again. And we're going to move on to Andrew Gall from Resolve to Save Lives. And I've said the North Carolina State Department, but I'm not sure that you're there anymore, Andrew. But Andrew will be talking about COVID data visualizations and dashboards from Wake County in North Carolina. So a bit of a switch for us. Thank you.
Yeah, good afternoon and good morning. Can you hear me all right?
Yeah, perfect.
Okay, great. Well, thank you so much for the invitation to speak today. So my name is Andrew. I'm a senior technical advisor with Resolve to Save Lives. And we're going to switch gears a little bit and not going to be talking about modeling. We're going to be talking a little bit about Wake County, North Carolina, which is one of the sites where Resolve to Save Lives worked in a surge capacity for about a year and a half on the US COVID response activities. So Wake County is a county with about 1 million people. You can see here the map. It's a majority white county in the US, has large populations of Black, African American, Hispanic, Latino, and Asians. It's a county where 7% of the population live in poverty, 10% would live without health insurance, which is an important factor in outcomes in the US setting. For COVID, they've had over 300,000 cases in this county, and disproportionately high number of cases among the Hispanic and Latino populations. There's over 1,000 confirmed deaths of COVID to date, and that's disproportionately affecting the Black and African American population. So as you can see, there's a lot of disparities in health outcomes. So I was part of Resolve to Save Lives embedded teams. So Resolve to Save Lives worked across the US at a national and a high level advocacy level, but I was part of one of their jurisdiction teams that worked directly with the county's public health authority to provide technical assistance. And I worked with a team of 4 other individuals, including Lauren Brown, who's on this call. And we provided support in the area of epidemiology, surveillance, program planning, operations, program evaluation, spatial analysis, communications, media, community outreach, and education. So it was, as I said, it was a surge effort. And I just wanted to kind of explain that. And so I'm not affiliated with the Department of Health, but worked very closely with the Wake County Health Department in COVID. And so the reason I'm here today is because I wanted to share some of the work we did around timeline analysis. So just for a little context, so this is a very, very busy chart, and we're not going to walk through all of the time stamps here. But the U.S. public health system is a bit complex. It's comprised of 8 federal level, national level agencies, 51 state level agencies that work in health, and then there's also tribal governments, and then about 2,800 local governments that have some level of public health authority. So when we're talking about public health and social measures, they're coming from different levels. They're coming from the federal level that can affect, not just federal property, but transportation. The federal government does have jurisdiction over commerce and businesses. So the federal government can put into place public health and social measures. But then the majority of public health authority is legislated at the state level. So the states can also put into place public health and social measures. And then they have also delegated in most states in the United States, public health authorities actually delegated or shared with county and local level authorities. So I'm giving you this context to just kind of explain some of our complexity in terms of assessing policy level interventions, because throughout the pandemic, the different levels of government from federal down to local level have implemented different policies, and sometimes they have been implemented at the same time. For example, the stay-at-home orders, also referred to as lockdowns early in the pandemic. Those came pretty much at all levels at the same time. But over time, as the pandemic developed and the political situation evolved, different levels of government decided to do different things, and there were conflicts and not a very harmonized response. So anyways, to get to the chart, this is a chart from over a year ago. So this is a very current. This is from April 2021. And this overlays some of the major state level and county milestones in public health and social measures, as well as the clinical operations. So what we're looking at here, as you can see, we see some of the state of emergencies. You can see here in July 2020 was when the masking rules started coming in. And then the red text, these are the clinical interventions from the Wake County Health Department, where they started doing their mass testing sites. They added more testing sites over time. As you can see, as you get into 2021, the vaccination sites start to open up. So this is a relatively comprehensive timeline for these sort of policy and public health social measure interventions. And this analysis was not really meant to evaluate specific policies and clinical interventions. And I'm seeing, from the presenters today, how difficult it is, even when you're doing advanced modeling, to look at the causation. And I think, the policy makers, at the county level and the state level in North Carolina, where this work was done, would have loved to say, oh, we put in a mask mandate and then came down, or we started testing and then cases went down. I mean, so they would have loved to make that association, but unfortunately, the data, this is, you're seeing here, this is the case rate data over time, and even that there's some underlying data quality issues, and the data improved as time went on, but It's very hard to make a lot of conclusions from this, but what this sort of chart was used for was to give a snapshot of the trajectory of the pandemic, of the case rates in relation to how policymakers were deciding on different requirements and resource allocation, especially. See this is in January 2021. This is the Alpha variant peak, and this is a time when a lot of additional testing and then vaccination services were added. So this sort of lies as a backdrop for the policymakers to show, what they were doing to respond as the pandemic developed. So I'll share one more timeline. So this is a little bit more recent. Still does not include Omicron, so not super recent, but this is an analytical chart from the end of December 2021. And so this overlays the variant detection milestones and some of the reinfection data with the case rates, with the epi curve here. So this analysis was really to help. This was less for the policymakers, but more for the epidemiology team and the leadership of the COVID operations within the county to understand how their genomic surveillance response was going. And at the county level, most counties in the United States do not have their own genomic sequencing. A few do. Wake County does not. So they're heavily reliant on state and federal laboratories to get this data. But you can kind of see here. So this is the alpha peak here, January 21. Let's see if I can get my laser pointer on this. So this is the peak here. So you see, this is the peak of alpha, but alpha wasn't really detected until the downward trend of that wave. However, if you go to July 2021, Delta was detected, but relatively early in that surge. So there were some improvements. There have been some improvements in genomic sequencing. You see, Omicron was detected here, and if this chart continued, it would actually go off the scale shown here. So this is another kind of example of how we've used timelines over case data in Wake County. So this is my last slide. So these aren't timelines, but just to share a little bit of the work that Resolve to Save Lives was involved with Wake County. These are some of the dashboards that the county epi and operations teams developed this is the Power BI platform, Microsoft Power BI, to track the case rates and vaccination coverage by municipality. So, I gave you a quick overview of Wake County, but there's actually 12 municipalities in Wake County. And about a year ago now, the county leadership sort of delegated responsibility for masking rules to the municipalities. So these dashboards were created to help the municipal leaders make decisions about mask requirements in their community. So they kind of looked at this data either to justify mask rules based on metrics, or to justify not having mask mandates based on dropping case rates. This is also publicly available data. So this dashboard gives an idea of transmission risk and vaccination coverage to municipality at any given point in time. For those of us that worked within the county, we did some time series analysis looking at, I told you about some of the disparities at the beginning. We did some analysis on equity over time and things like that. So there's a lot more you can do with this data, but what's publicly available is more of a snapshot for the public and also the media, which is also soliciting data a lot. So so those are my slides. Happy to take questions, and just acknowledge my colleagues here, especially my colleagues Sun and Lauren, who were heavily involved in this the development of this work.
Great, thank you so much, Andrew, and appreciate your time and efforts today. Please do raise your hands for if you have any questions. We only have a couple of minutes left, but and it might be a little bit difficult to bring everything together. Julia, would you like to go first?
Hi, thanks so much for that presentation. I thought that was super interesting, especially the point that we struggle with here in the States all the time is this constellation of federal, state, and local public health entities trying to work together. And I guess this is a question for you, but maybe for others as well. How much is the US unique in that respect? I mean, we have so many different levels of government that have overlapping and sometimes almost conflicting responsibilities for public health. Do we stand out like we do in so many other somewhat unfortunate ways for having this challenge of public health? Or, I mean,
Yeah.
You don't hear that talked about too much in the international context. So just wondering about that.
Well, I mean, I wouldn't say it's the only country, and I'm not familiar with every country's public health system in the world, but I do know Brazil has a federal system as well, and there have over the pandemic response, there's been some struggles between the national and state levels for data and analysis and policy making. I haven't worked directly with Brazil, so maybe some colleagues, I heard some mentions of Brazil before, so maybe some other colleagues have more direct experience. But I certainly think for the US context, for a pandemic response, the fragmented system is probably the worst setup you could imagine for data analysis, first of all, because data has to be aggregated many times, and hospital systems reports, they're still using fax machines based on certain laws that are in place for public health reporting. So there's healthcare clinics and hospitals, and then there's health departments at county and state levels, and then CDC aggregates the data, but there's big delays. And so when you're talking about, especially early in the pandemic, when you're talking more about containment, waiting 7 or 14 days to get data, definitely hampered, the data analysis side of it. And then of course the response required resource allocation coordination at so many different levels. And we've seen in the US is there's been a lot of public health laws that have either been weakened or there's been laws passed in different states to reduce the authority of public health. And recently there's a court case where mask requirements at the federal level for transportation were struck down. So the CDC requirement that travelers in airplanes, public transportation, and other modes of transportation was annulled by the judiciary. So I think all those show that some of the disadvantages of a federal system where public health authority is at the most local level is that may work for local level epidemics, outbreaks, having the authority at that level. But when you're talking about a pandemic, which by definition is not even a national, it's an international crisis, so having a municipality that's responsible for a pandemic response isn't really, congruent with the challenge. And we presented the best data we could at the county level, but really, it is the higher levels of the system that needed to, or that have had to aggregate and make the most sense of the data and form the response.
Thank you so much, Andrew. I'm afraid we're going to have to wrap up there, even though I think there are a lot of questions, a lot of discussion points that we'd really like to follow through on. I I think what we would like to do is hold a modeling an IOA session again in the next few months. So please watch this space, and we'll follow up with an email with the details of the next session, which will be our last before the summer on the 24th of June. Thank you all so much. I realize you all have to attend other meetings, and thank you so much to our speakers today.
Thanks, everyone.